Hello and welcome to this talk where we'll be covering dysautonomia and exploring the dietary management for orthostatic intolerance, POTS, and headaches in the context of dysautonomia. Got no disclosures for this talk, and just a little bit about myself, which I won't go through in detail, but my name is Helen, and I'll be taking you through today's talk with a view that I'm a registered clinical nutritionist here in the UK, and I do work one-to-one with individuals with HSD and EDS, and headache is a specific specialty of mine, and that includes in the context of dysautonomia. So very briefly, this is a snapshot of what we'll be covering through this talk. We'll be very briefly just covering some definitions and some signposting to some really helpful resources, especially for those of you who are perhaps newer to either diagnosis of EDS and HSD, but perhaps some of the co-occurring conditions like dysautonomia or getting to grips with that side of things. And then we're going to be digging into some of the management strategies that can be potentially really helpful in managing some of these symptoms and thinking about being able to optimize our nutrition in the EDS and HSD context, and flagging as well the value of not only personalized care, but multidisciplinary or collaborative care, as it's sometimes referred to. So as October was in fact Dysautonomia Awareness Month, this is just a really lovely visual that the EDS Society actually have, just highlighting some of the common symptoms of dysautonomia. But what I will say is everybody is different and does not necessarily experience all of these, or they may only experience some of these at certain times or with certain triggers. But these are some of the more common symptoms. And when we're thinking around alterations to heart rate, blood pressure, feelings of dizziness, lightheadedness, and then changes in function of GI, bladder, temperature regulation, and sleep, for example. So very, very briefly, just some definitions for us to think about. So dysautonomia is also sometimes referred to as autonomic dysfunction, and it is a group of disorders that impact our autonomic nervous system. There are different types, and there's also a selection of symptoms, as we saw on the last slide. Orthostatic intolerance, or OI, is referred to those symptoms that occur during standing or being upright. And types of orthostatic intolerance include orthostatic hypertension, POTS or postural orthostatic tachycardia syndrome, sometimes just referred to as postural tachycardia syndrome, but also neurally mediated hypotension. So there's just some very brief definitions here, but for POTS, for example, it's really important to understand that there are different types of POTS. There's a wealth of resources available through the EDS Society, not least through their YouTube channel, and these are some active links, but I'm sure that these can be shared separately as additional links if needed. So just to bring in headaches and to flag, headaches can very much be a primary diagnosis, or they may be considered a clinical symptom secondary to another condition. And there's many mechanisms and triggers and reasons behind. As a clinical term, there's lots of different types of headaches that help us describe them. So tension headache, cluster headache, migraine headache, and there are many subtypes of migraine as well. And these are all sort of based and captured within the International Classification of Headaches to help clinicians provide a more specific diagnosis for individuals. But a very key factor I always reiterate is that an individual may experience more than one type of headache. So they, especially for example, those who experience migraines can often also experience at other times another type of headache. And this is why there is so much emphasis put on tracking and understanding your specific symptom presentation and the triggers, for example, but also to help give you the vocabulary to describe headaches. That can be really valuable in trying to understand and untangle the web of the types of headaches that an individual might be experiencing and what they're associated to, i.e., whether they're dysautonomia related or not. When they are, it can be as a result of insufficient orthostatic blood flow to the head and neck structures, or it perhaps may be as a result of spontaneous intracranial hypotension. And these are symptoms, or this is a symptom within 15 to 120 minutes of standing, but that would be relieved quite quickly when laying. So, like I say, this is just really important to find ways to work with your clinical team and medical team to explore and understand the types of headaches that you're experiencing to see what it's related to or not. So just moving on from some of the definitions and the background to think about what we're doing and how we can go about managing. One of the, or probably the two most common interventions or pieces of advice that are given by medical professionals, but also found on the internet or elsewhere, are around salt and fluid. So here you can see a selection of salty snacks, which typically have very little nutritional value. They may be convenient at times, but they offer very little to us in terms of nutritional value and support. Often they can be fried, so that can perhaps present difficulties for people to digest them. Or we may be looking at just adding salt to our foods and drinks. Sometimes we're recommended very large boluses of water, so a large volume in one go, but that might be really difficult if you have swallow difficulties or you have delayed gastric emptying. And then we can think about some of the sports drinks perhaps that get recommended or may be readily available, but how much sugar or sweetener do they have in, and is that an appropriate amount for you? And first and foremost is, has either or both your fluid and salt intake actually been assessed before we're making changes? And that is a really, really key piece of information. So as part of that, these are some questions that I would always advocate for being considered and asked by clinicians and yourselves. And all of these, in addition to considering what your health status is, what medication are you taking, what activity levels, or what's the ambient temperature like? Are you indoors, outdoors? Is the weather particularly humid? Is it a dry heat? Is it very cold, for example? So all of these other factors must be taken into consideration alongside making changes to our salt and our fluid intake as a first sort of line of action. And we also need to think about where there is perhaps excess sort of fluid loss. Is that through sweating, for example, because of activity or the weather, or even fever and illness? Or is it because we've got vomiting and diarrhea and we're losing a lot of fluid that way? Or perhaps, again, medication, as mentioned. So these questions alongside your own individual status is very, very important before making changes to be established. Very, very quick point on salt and sodium. Two terms often really used interchangeably, but they are technically different. So salt is actually made up of 40% sodium along with 60% chloride. But salt is what we think of table salt. Sodium is the single mineral, and is important when we're thinking about fluid levels within our bodies, but they are not equal. So 1 gram of sodium is the equivalent of 2.5 grams of salt, because remember, it's only 40% sodium is that salt. So just one to flag when you're looking at labels on foods, for example. And we can think about naturally occurring sodium, so that might just be in foods that we come across, and we might be adding salt, sodium to our foods, perhaps as a flavor enhancer. So when we're making something at home, but also we can find it in cheeses, we can find it in pestos, but usually as a result, because it's got Parmesan cheese, which is salty, olives, capers, things like that. They're already there. But we also find a lot of salt gets added to more processed foods because it is a flavor enhancer. So a lot of highly processed foods, but even like pre-made sauces, etc. So we need to be aware, how much are we having, and then what are the natural sources that we can use that are also really nutrient rich. When we're thinking about fluid intake, there's kind of two tacks to this. The first is the drinks, the obvious one. So are we consuming water? If so, is it tap water? Is it filtered? Is it mineral, sort of bottled water, still carbonated? And then what other drinks are we consuming throughout the rest of the day? And that may include some of the options that we have listed here on screen. Water is essential, to every cell and tissue and organ in the body, not least things like our blood. We're made up on average, we are 60% water, so it is essential. And we need it to have all of those liquids in our body as well. So our blood and our mucus, which is inside and outside, some of those things we don't always like to think about, but it is essential. The important factor is, if we're looking to increase our fluid intake, is we should be doing it slowly and only once we understand how much we're already consuming. So any changes, and that might be an increase or a decrease, in fact, if we're actually over consuming water in certain situations, we should be looking to do this in a very measured way. And if you're an individual who experiences issues with swallow, then absolutely this should be done under guidance and support to look at strategies to best support you. The other tact we can think about is actually what fluids we get from foods, which we don't necessarily always think of first of all. But water dense foods such as fruits and vegetables, etc., can be considered. Also, I mentioned smoothies and proteins on the shakes on the previous page because they are a liquid, but actually we start to think of them often, if they're prepared appropriately, as more of a meal, because they should have some proteins and some fats and some carbs, as was discussed in the earlier sessions today, to make it a more complete food encounter. But again, we need to be thinking about this in the context of what we're already doing. And aside from the what we're eating or consuming, we need to think about the kind of how we're also going about. So thinking the timings that we're having food. So often smaller, more frequent meals with less long periods between is an approach. So that can be a factor, but that might mean we need to adapt the size of our meals, because we don't want to overeat and impact our digestive tract too much if gastroparesis or delayed gastric emptying is a factor. And understanding triggers is, I'm working my way up the slide here, but understanding the triggers is really, really important. What is it for you as an individual that perhaps may trigger a symptom or exacerbate a symptom? And for example, a higher carbohydrate meal may be something that is putting more pressure on your system, or things that are difficult to digest. So switching that to something that's easier to digest, and perhaps where appropriate, with guidance as a short-term strategy, something that's blended may be easier, and that might for your body to digest, but that might just be at a certain point in the day, for example. So the core sort of dietary approaches that we would always be starting from is assess first and foremost. So understanding your health status, your nutrient status, associated risks for, say, swallow issues, or is somebody at risk of malnutrition, for example, because we're just not able to get the right amount of nutrients in. Understanding the type of dysautonomia or orthostatic intolerance an individual has. Salt, usually looking to address this first of all, rather than fluid first, so that we don't create an excess excretion situation. So up to 10 grams of salt, which is 4,000 milligrams of sodium per day, but assess first and very, very gradually, under guidance, should this be addressed. Then on to fluids. Typically, we're looking up to 3 litres. But again, what are you already having? What is your individual circumstance, environment, temperature, activity, etc.? All should be changed under guidance and incrementally increased or perhaps decreased if that's appropriate and monitored. Now, supplements are often something that is spoken about and used clinically as well, either as a short term intervention or as a bit of a toolbox or sort of toolkit strategy. And what I would say is what we're looking at in formulated versions are that each serving should have 500 milligrams of sodium to 100 milligrams of potassium. That ratio is important. And just one example, and absolutely there are a huge number on the market these days, but many of you might be familiar with potassium, which is by a company called Salt Stick, and this has been formulated for certain types of dysautonomia. It's now available in capsules, fast chews, and also a powder, which can be made into a drink. But again, this should be looked at alongside need, but also existing intake and geographical location, temperature, etc. So just to touch on some of the challenges that we might need to consider when looking to change any aspect of our dietary intake, but especially when we're thinking about volumes of fluid and salt and how our meals are formulated. In the context specifically of EDS and HSD here, where we're thinking, well, actually, are there chewing concerns? Do we have dental or oral issues? Swallow is a really big one, and I know we have a talk later in the day specifically covering swallow concerns and safeties and strategies. So that's something to look out for. Upper and lower gastrointestinal motility. So again, is there an alteration in that gastric emptying? Are we someone that's experiencing more lower evacuation challenges? And again, there's some amazing talks across the rest of the day to think about some of these factors. When we're thinking about fluids, bladder dysfunction, which we do see a lot in EDS, can be a real challenge if we're looking to increase the volume and we're having either difficulty voiding or we have an incredibly sensitive bladder and we're constantly having the urge to void. So we have to be able to take that multidisciplinary approach and that holistic whole person view on a situation. And fatigue, I mean, that's a huge one. Just being able to prepare and get, the food or the fluids that we need. Alongside that, actually executive function. So being able to plan, often we're looking for intake of, say, fluids and the salt across the day rather than going, oh, heck, I've got to remember to do this. And trying to drink 1.5 litres of fluid in one go is just not feasible. So being able to plan and structure and create those habits and routines is really important, but that might be a challenge. So coming up with strategies. Taste and texture as part of a sensory alteration might be a real challenge if salty foods actually are just not something that appeal or you get on with or you have a real challenge with. So how can that be factored in? Knowing if we're even hungry or thirsty. Often we see this a lot through the neurodivergent populations where actually some of those cues are lacking and those chemical messengers that come in to factor in. So just really being aware and again working with somebody to help identify how you can factor that in and perhaps plan for it. Thinking about the timing of food and fluid intake and the times of day that you need or can have these things. And also thinking from a tolerance, or do you have established food allergies or sensitivities or factors we're working on to change our dietary habits? And again, this needs to be worked on with an individual sort of basis with a clinician. So just quickly, the last few points to think about are just some day-to-day considerations, and we've touched on some of these already, but just all of these will factor into what you may then need to adapt from a symptom management point of view and strategies through diet, fluids, and also lifestyle strategies. And often, we really advocate for these to include Patient and self-education, attending days like this is fantastic to be able to gain a wealth of information from clinicians that you may not be able to get, readily access to day to day, and to be able to apply it to your own situation, thinking about those personal triggers and your own situation, but also where you'd like to get to, setting some goals of where you'd like to work towards. Through that, thinking about how you can go about doing that, and that may involve adapting some habits and routines to factor in some of those things, like a routine or your geographical location and temperature, for example. And then we can think very sort of strategically around our sort of standing posture or our seated posture, i.e., typically people may be standing in a kitchen to prepare or cook food, but could this be done sitting down to make it more achievable so that a meal is able to be prepared? And then breathing patterns is just such a wonderful way to think about support for our nervous system as a whole, and that absolutely factors into dysautonomia. And I don't have time to go through this now, but I'm sure it's going to be a theme that's probably touched on throughout the day with some of the wonderful experts that we have speaking. And lastly, but not least, just to really flag some of the considerations around multidisciplinary care, of which nutrition and lifestyle strategies can be crucial when managing dysautonomia. But that's not to disregard all of the others. Absolutely medical management, perhaps with medications, is needed. And in the very first instance, for assessment, then thinking around occupational therapy for adaptations. Psychological support, compression garments may be appropriate, and some of those lifestyle strategies that we spoke about. So, just in summary, medical assessment allows for that diagnosis, guidance, and referral opportunity. You working to understand your triggers with your clinicians and some of the barriers to wider considerations is the starting point to formulate your plan of action. Any changes should always be low and slow or slow and incremental. And MDT can be a real basis to providing that toolkit for you for condition and symptom management. These are just some papers that we've used today. Thank you very much for your attention. Enjoy the rest of your day.